Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by sMater, an Australian leader in healthcare for more than a century. My name's Gillian Whiting.
And I'm Catherine Cooper, Clinical Specialty Coordinator for Mothers, Babies and Women's Health at sMater.
And we're coming to you from Meanjin, the land on which this podcast is being recorded. Today we are joined by Dr Pita Birch, Director of Neonatology at sMater Mothers Hospital.
Pita has worked at sMater for 6 years, and prior to that was a neonatologist on the Gold Coast, in Melbourne and Auckland.
Pita is interested in ensuring the provision of family-centred care in neonatal critical care units and promoting quality improvement, infection prevention and respiratory support. And he's also trained in point-of-care cardiac ultrasound.
Pita has a preterm baby of his own who's now 25 years old. Today, he's joining us to talk about how to care for premature babies once they're born.
sMater.
Caring for the community for more than a century.
Innovators in health, education and research.
Home to world-class clinicians.
State-of-the-art facilities.
High quality, patient-centered
Australia's
care.
largest and leading
Turning
maternity.
scientific discoveries
Educating
into
the nurses,
life-changing
healthcare
outcomes.
advancements,
Compassion,
provider.
Integrity.
We are sMater.
We are sMater.
We are sMater.
This is sMater.
Hi Peter, welcome to sMater.
Hi, thank you.
How do we care for premature babies once they're being delivered? What's the main priority?
There's a number of priorities, and I guess even before they're delivered, it's really important that there's good communication and preparation for the birth of these babies. From our perspective as neonatal specialists, the number one priority is transitioning these babies to outside the womb life and getting them breathing.
And how do you do that?
Look, there's a number of ways we do that. We try and encourage the babies to spontaneously breathe by themselves, and then we provide them with some breathing support. It's something that we all take for granted, but a premature baby, in fact, any baby that's just been born, has lungs that are full of fluid. They don't have a background of inflated lungs. They don't know what it's like to breathe air, and it's something that's completely new and needs to be stimulated with them. Most of that stimulation comes just from being born, but for premature babies that may not happen, and we need to give them help. So we give them help by giving them gas to inflate their lungs with pressure, and we've done quite a lot of innovations in how we might deliver that, and sometimes we have to go down a pathway of doing the breathing for them.
So, Peter, what other things can be done around helping babies to breathe when they're first born?
Look, I mean, there are things that can be done even before the baby is separated from mum. So delayed cord clamping is something that we do to try and assist babies in transitioning. There's some evidence that shows that improves outcomes for premature babies, and it's just a matter of pausing before we cut the cord. So the baby is delivered, and then we wait for a minute before we cut the cord, and we use that time to stimulate baby to breathe and transition to outside life while still being supported by mum's, the placenta and mum's circulation. There may be some help in terms of extra blood the baby gets, but the evidence suggests that it's around assisting the babies to transition to life outside of the womb while still be supported by the placenta.
And is that a discussion that you obviously need to have with the parents? When does that happen, and what's the nature of that discussion?
Yeah, look, I mean, that discussion is something that we would try and have even before the baby's born. It's really important for us to try and give the parents an idea of what having a premature baby is like. So we as best and as often as we can, we like to meet with the families well before their baby's born to run through that information. We've got extensive parent information sheets that we give to parents about what it's like to have a premature baby, and within that we would have a discussion about delayed cord clamping. If there isn't a time for that, we should always do that in our time out. So in the birthing room, either a delivery suite or the theatres, we would have a discussion with the teams involved to say, this baby's coming prematurely. The best practice would be to do delayed cord clamping. Is there any contraindications to doing that? And if not, we would go ahead, and the parents would be, or mum particularly, would be part of that discussion to know that that's happening.
Can you talk us through a bit of details about it? Like exactly how do you do it? How long do you do it for?
Yeah, so the first consideration is to make sure that the baby's kept warm. So we're having a baby that comes out that we're not wrapping up straight away. So we actually delivered the baby into a plastic poncho. So it has a little it's a little plastic sheet that we can wrap around the baby with a headpiece that we can tighten up so that the baby is fully covered over so that they don't lose heat from evaporation. And then we place the baby on either below mum or on her legs if she's in on operating theatre, and the midwife will be there supporting the baby, and a neonatal specialist will be there observing to make sure that the baby looks okay. Because if the baby is still struggling and not transitioning and needs further resuscitation, we can't persist with delayed cord clamping if the baby actually needs help immediately. So we watch to make sure that that's okay. If the baby is doing what we hope and is transitioning, we can stimulate and we can help the baby to start to enjoy ex utero life. And if that's going well, we do that for a whole minute, and we'll usually sort of do a countdown, 5 seconds to go. 1 second, you can clamp the cord now.
How important is that skin to skin contact? And you said it's not very long, is it, in this situation? Yeah,
it's not truly skin to skin like as we would see that. So that contact isn't part of necessarily a big part of what we're doing, because for a mum who's delivering a baby vaginally, the baby is often held either just at the entrance there so it's not lifted up too high. Sometimes it can be placed sort of lower on her pelvis. And in theatre, it's placed on her legs, which are covered with drapes. So it's not really about that skin-to-skin contact, which is something we will try and do as soon as we can afterwards, depending on the stability of baby. But it's more about baby getting used to that life outside of the womb without being completely unsupported.
You mentioned at the very beginning that one of the first things you do is make sure there's no contraindications. What might be some contraindications?
Oh, look, if the placenta is already separated away from the womb, then there's not a steady blood supply that's coming, so that's not really a good idea to do the delayed cord clamping in that situation. And if there are twins where they share the same placenta, so some identical twins will have a shared placenta, and if that is the case, then there's a risk that during that delayed cord clamping, blood will not go in the right direction. So they're the main two contraindications that we would have.
Delayed cord clamping can have an impact on cord blood collection should the patient wish to donate the cord blood to a public cord bank. Delayed cord clamping may mean there is a higher chance that there will not be enough blood left in the placenta for collection. The volume of cord blood collected is critical for successful transplantation.
Those the little ponchos you talked about before, the neo wraps.
They're a version of the neo wraps. Yeah.
How effective are they in preventing hypothermia?
Yeah, they're really effective. They help us a lot. And there's some really good evidence about using plastic wraps, and we've just converted those to using them during the delayed cord clamping as well as during the resuscitation. And then when that minute's over, we take the baby to a heated resuscitation table that makes sure that we are absolutely prioritising thermoregulation and keeping babies warm.
And Peter, really tiny babies have pretty friable skin. Does that neo-wrap have a protective effect, or would there be some instances where you wouldn't use it?
No, it's not. It's not particularly protective, and it's soft and it's healthcare grade material, so it's actually made for wrapping up small babies. So it doesn't tend to cause skin injury, and I can't think of a contraindication to using the wraps that we have.
What other methods do you use to keep the baby warm?
In the past, we've used heated mattresses to put babies on. Currently, we have some really powerful heated tables that we don't need to use the heated mattresses for, and they keep babies warm. But part of the really important methods is actually monitoring temperature as well. So taking the temperature regularly, because keeping the baby in a normal temperature is important. It's not just keeping babies warm, it's keeping them in the normal temperature range, because we've certainly had a lot of quality improvement work that we've done to make sure that babies are kept warm, and part of that had actually led to some babies being too warm. So we need to keep an eye on that and regulate the temperature devices that we use to maintain a normal temperature.
With all those different devices and methods, how long does the baby stay either wrapped up or being kept warm? Depends on the situation.
It's pretty standard. So look, the wraps that we use are for extremely preterm babies. Babies who are sort of over a kilo, we would tend not to use the wraps. They don't need to use those, and we would use just a heated mattress or a heated resuscitation table. But our really tiny babies, they stay in those wraps until we get them up into their their permanent incubator or their incubator for the next 2 weeks, and we use humidified, heated gas within the incubators. So the incubators that we're using, we maintain a humidification around 80 to 100% for those first few days, and for the very little babies, and they will the tiny babies will stay in those incubators for weeks to maintain their temperature.
According to the Australian Institute of Health and Welfare, almost 1 in 5 babies require admission to special care nurseries or neonatal intensive care units. Babies are more likely to require admission if they were born preterm, First Nations, of low birth weight, or born as a twin.
Going back to ventilation and breathing difficulties, how do we care for babies at that point?
Yes, and most premature babies will need some support with their breathing. And we've made a real push in the last few years to try and reduce intubating premature babies in resuscitation at delivery. So we talked about the humidified, heated gases, and we're using those for respiratory support. So we will actually place a spontaneously breathing baby on CPAP, so that's continuous positive airway pressure, to provide them with airway pressure to hold their lungs open, and we'll do that with a little mask on their nose and a snorkel setup that we apply almost immediately after they're born if they're spontaneously breathing. They might need some extra pressure and extra support for a period of time, and then we'll put them back on that CPAP system.
Why is humidification so important, Peter?
Well, the airways can dry out. And if we're giving dry gases that are provided out of the wall, those gases are dry. They will dry out the airways, and they will they're harsh and can cause airway damage. But also the humidification is important for preventing water loss as well. So you lose, premature babies lose a lot of water out of their skin. They're not good at retaining it, and they'll lose a lot from their breathing. So there's a lot of insensible water loss, and that we have to try and maintain when we're giving fluids. So preventing that by giving humidification either in the incubator or in the airways is important to prevent water loss.
And you talked about bubble CPAP being like almost first line. What if that's not effective?
Yeah, so if that's not effective, I guess we've got 2 methods. We try, as I said before, we try not to intubate babies at delivery. So if bubble CPAP is maintaining the baby's breathing, but their oxygen requirements going up, and it looks like they're not going to be able to stay on bubble CPAP because they need more support, we can give them surfactant, which helps to reduce the surface tension in the lungs, opens up the airways, and allows the babies to open their lungs more and breathe easier. So we can give them surfactant via a little tube that's almost like a 14-gauge cannula size tube that goes into their trachea while they're on CPAP. So we intubate them with that while they're on CPAP. We leave that in the airway while they're still spontaneously breathing on the CPAP machine, and we put the surfactant down into their trachea. They inhale it into their lungs, and it spreads it better through their lungs.
For how long would you do that?
The actual process itself would take 5 minutes to do, and we would try and do that within the first few hours, and then we'd repeat it in 6 hours' time if the baby still needed that. And we would do 2 or 3 doses of that as required.
And what does surfactant actually do, Peter?
So we don't think about our own breathing. And I sort of said before, we don't think about breathing, just comes naturally to us. But every single water-air interface, there is surface tension, which is why little water boatmen crawl along lakes and you get droplets that form. So at every water-air interface, there is surface tension, and it pulls the water molecules tight together. Now, babies are essentially watery, and their lungs are watery, and then they breathe air into that. So as soon as you get that, you get alveoli where there is an air-water interface. And so the natural physics of that is to pull the alveoli closed. So surface tension continually wants to collapse your alveoli and collapse your lungs. What surfactant is a phospholipid molecule where instead of having an air-water interface, you deliver surfactant, and you get water, phosphate, lipid, air. And you don't have an air-water interface anymore. You get no surface tension, and there's no drive to collapse your lungs. So as all mammals do, the pneumocyte cells will release surfactant continuously to line the alveoli on a regular basis so that we don't even have think about surface tension as being a problem. But premature babies have immature systems to release and produce surfactant, so they don't do that spontaneously themselves. So they're fighting against surface tension, wanting to collapse their lungs down.
So that combined with CPAP keeps some air in the lungs at all times, right?
Correct, yeah. So when we breathe out, even if we breathe out as hard as we possibly can, our lungs are still inflated. Whereas when a baby is born and they breathe out, they've got no air left in their lungs. So they have to establish air inside their lungs even when they breathe out, so that their lungs don't completely collapse. Otherwise, every breath is like your first breath. And so having your lungs expanded makes it much easier to breathe. It's a bit like the analogy of the hardest breath to blow up a balloon is the first few breaths, and then it gets easier. So once you get your lungs expanded, it's much easier to breathe once they're open. So providing CPAP opens those alveoli up. And if the baby can produce their own surfactant, then opening the airways and opening up the alveoli means that they can then secrete the surfactant themselves into that space. Whereas if the lungs are collapsed, there's nothing to secrete surfactant into. So CPAP as a first line will hold the lungs open to allow surfactant delivery, surface tension to go away, babies to breathe easier. If they can't do that themselves, we give them surfactant to try and line those airways and then hope they do that themselves. If that still isn't working, we will put a tube down into their lungs, secure their airway, and deliver ventilation to maintain that breath in various different ways.
The Australian Institute of Health and Welfare reported that of those babies requiring resuscitation in Australia in 2021, nearly 32,000 were resuscitated by continuous positive airway pressure, while nearly 22,000 were resuscitated by a suction. Cardiac compressions were the least common form of resuscitation, with only 769 instances recorded.
There's a lot going on clearly at this point. Putting myself in that position of a parent, how do you break all of this down at the right time, the right message at the right time?
Yeah, so we talk about that before the babies are born. So if we get a chance to talk to parents about that, we would talk to them about why your baby needs breathing support. And we've got parent information sheets at various gestational ages that will explain what the likelihood is of your baby needing breathing support and why. There are also parent information sheets just on breathing support. And so we do what we can to try and explain to parents what that means. We do tend to use the balloon analogy. If we can give your baby CPAP and hold your baby's lungs open, it's easier to breathe. I tend to talk about surfactant as a lubricant to make it easier for your baby's lungs to open and close and easier for them to breathe. And then we talk about ventilation support. And it's really important when we talk about ventilation with parents that we talk about it in a way that this is supporting your baby's breathing until they get bigger, stronger, and more mature to breathe on their own. Because a lot of people talk about ventilation as life support, and it's something that you switch off at a period in time. So it's not. This is something that we do to maintain babies' breathing while they're mature enough to do it on their own. And we've got other methods that we can try and use to help them progress to breathing on their own as well.
So we've talked about the priorities, babies delivered, breathing, thermoregulation. What else do you need to consider?
Look, I mean, we need to consider the whole baby. There is a lot in our consideration. Some of the really simple things are around how much we handle and move babies. As you can imagine, really small, fragile, premature babies, they are fragile. And one of the really important things we're trying to prevent is any harm to the baby. And premature babies are at risk of having bleeding within their brains. So things like intraventricular hemorrhage, where bleeding into the fluid around the brain can cause injury to the brain tissue itself. And then that has long-term impacts for that baby and the family. So things that we can do to try and prevent those babies from having injury to their brain is really a priority, particularly in those first, we call the golden hour, but in the first sort of 48 hours, just reducing how much we handle babies. Even as simple as maintaining their head in a neutral position so that we're not moving their head around and potentially disrupting the flow of blood to the baby's brain is really important. We've created some quality improvement projects here at the Mater around trying to reduce handling, and that's really about a team approach. Who in the team is responsible for what part of their role in the resuscitation, and therefore what role they have in moving and handling the baby, just so that there's a structured approach to make sure that the baby isn't handled by a whole lot of different people and therefore moved around a lot. Within that, though, it's really important that there's some positive handling that goes on as well, which does mean that even though we're not trying to move and position babies a great deal, we still want skin to skin. So we talked a little bit earlier about skin to skin after delivery. What we're trying to do is, as soon as mum's recovered from the birth, which is a little bit longer if she's had an operative birth, then trying to get that baby onto mum's chest and some skin to skin as early as possible. And we see that as positive handling and positive touch, and that probably has positive effects rather than increasing those risks of brain injury.
Peter, some of that sounds really quite new from when I trained, donkeys years ago. What has changed?
There's been a real focus on quality improvement in the preterm space. It's something that's been really pushed across Australia and New Zealand. We have regular continual practice improvement meetings once a year. We're always talking about what we can do to try and improve the quality of care we provide to babies, and particularly in the area of prematurity, that has there's been a lot of pushes to try and translate what we think is good practice into actually practicing it, putting together bundles of care so that everybody is aware of what we're trying to do. So I mentioned briefly before about the golden hour, and so that stuff around trying not to handle babies and trying to do our best so that they get positive handling, not negative, stressful handling has been a really important part of that. And that starts with delayed cord clamping and trying to improve transition. It's trying not to intubate them at birth, so providing humidified CPAP straight away. Try not to intubate them to give surfactant, so giving non-invasive surfactant, so surfactant with minimally invasive or less invasive surfactant administration, and then reducing the amount of handling that we have, right down to not necessarily putting umbilical lines into all of our premature babies, but putting in a drip, which is quicker, and then maybe putting in more definitive access a couple of days down the track when they're more stable. So all of that has come about in the last maybe 5 years, and it's also coincided with our pushing the borders of viability. In fact, we're trying not to talk about borderline viability anymore, but extreme prematurity. So babies that are 22 and 23 weeks, which when you trained, Catherine, wouldn't have been resuscitated at Mater Mothers Hospital, are now offered routine resuscitation. And 24 week is very, very much routine. And we would be advising parents that we would recommend resuscitation at this gestation. So those conversations have changed, and that change in those conversations has coincided with our trying to improve the practice to improve the outcomes for those really little babies. And I've mentioned a few of those things.
So many challenges. Peter, thank you so much for that today.
Quite all right. It's been a pleasure.
Peter, before we go, we'd like to introduce you to a little segment we call the checkup.
So we have questions. We want to know more about you, the professional, and you, the person, as well,
Okay.
Peter. So Catherine has 5 quick questions.
Okay.
They're not tricky. Are you ready?
Maybe.
Okay. Who was the last person you FaceTimed?
My wife.
What was your first concert?
My first concert. I think my first concert was probably some sort of metal group. It was possibly Guns N' Roses.
Nice. Nice, we'll go with that. If a genie could grant you one wish, what would it be?
Oh my goodness. That is an extremely difficult question. More time.
More time. What's your superstition?
Is this awkward, Peter? I'm not sure.
Oh no, I'm a very scientific person, so I don't believe in superstitions rationally, but I do internally, as most people actually do. What's my superstition? I play squash, and whenever I play squash, I have to put on my socks the same way and wear long socks.
I love it. I love it. Very scientific. And finally, if you could impart one piece of knowledge to a medical student, what would it be?
I guess it would be make sure that you make sure that you have good mentors around you. Have people that will support you, people that you can go to, and people that you can trust to talk about things, because a career, particularly a career in neonatology, a career in obstetrics and gynecology, you see a lot of things that are impactful, and I think you need to have processes to manage all of that. So I think it's really important right from the outset that you have mentors and supervisors to guide you.
Wise words.
Yeah, wonderful. Peter, thanks again so much for joining us on sMater. For those of our listeners who are at home or in the car or just having a well-deserved break between patients, thank you for tuning in.
Please join us for our next episode where we talk about how to handle extreme prematurity with Dr. Luke Jardine, Deputy Director of Neonatology at Mater Mothers Hospital.
See you next time on sMater.